it would be great if you can share a bit about how this whole infant mortality piece of work came about.
In April of last year, there was a leading article in British Medical Journal, which identified how the perinatal and infant mortality in Birmingham was so high. There was no doubt that there was a problem. And I think what was missing at that point in time was, what are we going to do moving forward? I have a background in pediatrics, also public health, and also dealing with the minority community where the problem is highlighted. So it was something that excited me so much that I just felt that maybe I've come at the right time, where everybody's willing to cooperate, everybody's willing to kind of take action and committed to the tackling of this big problem. Then we decided to choose the 3 work streams. Work stream 1 would be creating research evidence. Number 2 was innovation and co-production of solutions. The third one was the implementation and quality assurance. Also the quality improvement. It's the culture that may need to change within the organization in terms of, this is a major problem. We are all here to tackle it. As an independent chair, my role is probably to influence those people, inspire the people on the board and the other people that they are working with to bring about the change.
What I'd like us to do is explore how you think the seldom heard community research work can enhance the work we're doing around infant mortality in Birmingham.
Many of our women, they're not really accessing information or places where they can get a better understanding of preventing infant mortality. And I think the work that we can do is to raise that awareness and link it with cultural habits, cultural situations that are meaningful to those women.
The women involved in this project, they're local women. We've been able to work with you to train these women, to support these women to gain the skills to go out and do some research. Because they're local women, they've got a keen interest. They want to see improvements in their community.
These women will have built relationships. They know why a woman might react in a particular way to a particular situation because they get it.
And I think, now we've got this group of women, it'd be really good to see what they can unpick.
What do you think it is that the Infant Mortality Task Force is going to do in terms of making a difference to infant mortality?
I think how it can make a difference is by supporting people that weren't supported before, in terms of just getting together with people who have suffered, in my case, losses due to genetic diseases. What I've done so far is a lot of little projects, to be honest, and it's made a huge difference to me because I feel like I'm doing something that's making tiny bits of difference to people. So I raised some awareness in schools. That was a pilot project because I got married at 16, and at that time, if I had known about these risks with cousin marriages, I could have challenged my parents. So it was important for me to have had those facts at that time. So I believe in prevention, just giving young people that information so they can make an informed decision. That was really positive because of the way they were listening and the questions they were asking, and they were really interested and they wanted to know more. Other projects that I've been involved in have been to do with supporting women within the community to access maternity services through the Maternity Voice Partnership, getting through to those women who health professionals will say are hard to reach, but they're not hard to reach. They're there. We just got to go to them. So I feel like I'm making a difference, all because of this work that's come from the task force.
So what I'd like to hear from you is what you think of the project and how you think we need to take it forward.
I feel like it needs to be more detailedly explained in different places because I know, like, I've had people that I know say that, like, older generation people tell me that, oh, it's just stuff that's made up, it's not true, it's okay to have a child with someone you're basically related to, which didn't make sense to me at all.
Because it's an actual story, I believe that people would take it more seriously than someone who would just pretend to do it to make like a lesson out of it. So because someone actually came in and told us, it makes it not only more believable, but it actually puts it into a perspective where it's like, yeah, we should probably start talking about this more.
So obviously we talk about this a lot with our pupils, but it doesn't It doesn't have the same impact as when we had somebody who can speak from life experience.
That lived experience is key. And this is one of those opportunities that it will absolutely complement everything that we do.
Because it can be quite sensitive in terms of the genetics element.
I think it's how you approach it as well, and not making a big fuss of it and saying actually it's just something to be aware of.
It was right and proper to integrate it within a bigger topic. And actually, I think some people feel very uncomfortable, particularly outside of that culture, that we're preaching to you that this is wrong. And I think that's where the visitor was very powerful as well.
She was so powerful because the pupils were able to have that conversation with her and to ask her direct questions, fitting in with the fertility conversation anyway. It fitted perfectly there.
This is a real way into schools through education and supporting, trusting us to know what issues are important and that you can have impact on.
Consanguinity is definitely one of the factors. People have started to talk about this openly. However, there are other causes like maternal health prior to conception, how prepared they are, how good care they take of themselves, and delivering premature babies, which is also a major cause. I would not want the end point of this task force be a report which says, this is what we found, this is how we should be moving forward. What I wanted was, as we move along, I wanted to see the changes. If we could start with the short steps, next 3 to 6 months, what should be done by 1 year, and then a longer term plan. So let's first focus on avoidable causes of perinatal and infant mortality. Ethnicity should be recorded in 100% of the maternity patients. Those that are at risk should be flagged and monitored carefully. All pregnant women advisory obesity, complicated premature delivery should only be done in the level 3 hospital. Then treatment pathway should be developed and followed in the maternity hospitals. And the community facility to be provided for minority women. Letting the women do their own peer education to the other women in the minority community, as well as in the schools to youngsters, making them understand the adverse outcome that they might get if they are in consanguineous relationship. However, genetic testing is available and that should be done earlier. There are 10 other areas in the country who've got exactly the same problem. If we find the solution in Birmingham, that solution can be transferred to the other regions as well.